Okay. Um, hey everyone, this is Dr. Young. This is going to be the third session of the QI curriculum, and the focus of today's activities are going to be on planning your change and specifically what is the current state. So the reason I'm recording this is just so that those of you who cannot make it to the live session get a chance to review the material. This is the first recording, so I'm going to go over a little bit of what I had gone over in the last two sessions as well. Hopefully it's still pretty brief, but we'll just kind of go through and see how we go. So this is an overview of the QI curriculum. I won't read this off, but there are objectives. I think the one thing I'll mention is in terms of what we've covered so far is a generalized approach to quality improvement, an aim statement, and then the current state. You can see that we're not getting to planning or implementing any changes yet. We're still in this planning phase. And again, the main goal is that each of you will complete a resident-led QI project and also disseminate your work in some way, whether regional ACP next year, Solomon Scholars, or Grand Rounds presentation. This is the general sort of curriculum roadmap we're following. For the last two sessions, we were going through an introduction to quality improvement or entering into planning your change. This on the right is the IHI, the Institute for Healthcare Improvement Model for Improvement. And this is the model we're following. We talked a little bit about lean last time, and we will continue to sprinkle in and kind of highlight how a lot of what we're doing where it fits into the lean approach, the lean A3 approach to quality improvement as well. And again, just to review in terms of the model for improvement, we start by defining what are we trying to accomplish, establishing how we will know that a change is an improvement, what change can we make that will result in improvement, and then we go into this plan, do, study, act cycle. It seems like it probably feels like we're spending a lot of time around what are we trying to accomplish and how will we know that a change is an improvement. But unless we really get that groundwork of our QI project established, your QI projects, and I shared a few examples in the first lecture, but your QI project can either go nowhere or you'll end up somewhere far from where you wanted to be. Or you'll end up somewhere and you have no idea if you're actually improved the thing you're trying to improve. Again, last two sessions were introduction to quality improvement. In the first session, I gave an overview of quality improvement. Last session, we talked about QI frameworks, specifically the lean and A3, comparing it to the IHI model for improvement, and we talked a little bit about data and measures. Just reviewing some of that, on the left here, you see the lean A3 plan, do, check, act. And so within the lean A3 kind of framework, there's a focus on clarifying the problem, breaking down the problem, target setting, doing a root cause analysis, developing countermeasures, which are your changes, seeing your countermeasures through, evaluating both the results and the processes, and then standardizing successful processes. And you can kind of see the parallel of this approach to the IHI model for improvement that I just went through. I won't dwell on this, but this is a table comparing different components of the model for improvement to A3 problem solving. And then we'll do a progress check when we have our live session, but I'm hoping that very soon each group will have their aim statement, will have some data that they're charting, and then we'll have some progress on mapping the current state, which we'll talk about today. And here's some examples of aim statements. Again, should be specific, measurable, attainable or achievable, relevant, and timely. Some examples given here: reduce the percent of inpatient glucose measures from whatever percent at baseline to whatever percent by a specific date, reducing readmissions. And again, these are suggestions. I don't want you to, I mean, if you want to use these, you can, but I don't know necessarily that each of these is necessarily improvement, or specifically this last one, like reducing repeat RRTs. I'm not sure if that's an aim that is actually an improvement or not, but that's, for your group and your faculty mentors to decide. So today we're going to start talking about planning your change. I broke this down into 3 different sessions. Today we're going to talk about what is the current state. Next time we'll be analyzing the problem, and then the session after that will be planning change. And so you can kind of see that more than half of the QI curriculum will have passed before we even start planning change and doing change. But I hope that you'll see how setting this groundwork really makes the implementing of change really natural once you have the groundwork set out. And so what are we going to talk about today? Mainly just 2 things, process flow mapping and charting data. And both of these are ways of defining the current state. One is around mapping or charting what the current process is. Sometimes it's called a flow map, sometimes it's called a flow chart. It depends on if you're doing the lean A3 or the IHI model for improvement, and then charting data. And we talked a little bit about data last time, but I'll kind of go over it again because I know a lot of you weren't there. So let me switch my sharing to this video. And this is a short video from Stanford. They have a really great program called the Radiology Improvement Team Education. They actually have a lot of really great videos on YouTube. And so for those of you that are interested in learning more, I think it's a great resource to look at. So I am going to mute myself. Sorry, I am trying to figure out how to make this window go away. I don't want that. Okay. And I'll send the links to these videos as well. So let me make this full screen. Sorry for the troubleshooting, and then we'll go ahead and start the video.
Hi, this is Candice Garcia, Quality Manager in the Department of Radiology at Stanford University, and this is the Radiology Improvement Team Education course. Today's discussion is on current state. When I was in school to become a nurse, it was incredibly nerve-wracking to know that I was responsible for these very sick patients. I would be on the floor and the alarms would go off and the worst-case scenarios would play through my mind. I mean, I might as well grab the crash cart on my way into the room. However, despite my initial thoughts, I was taught there was always a very clear first step. Go and check the patient. No matter what you thought was happening or what you were going to encounter, you had to go observe the situation for yourself to be able to make a good decision. The same thing goes for process management. The first thing you do is go and see it for yourself. We observe how the process works without interruption. At first, we don't ask people to explain things to us, we just watch. Then, after we've spent hours observing the process, then we could be in a position to start mapping it out. We call this a process map. This is a step-by-step account of what we've observed. We make no judgments about how the process should be, we just map out how it currently works. Now, chances are that people will be doing things differently, so we want to map out the most common way of doing things. We always want to work in teams with the people on the team who are actually doing the work every day. We then create a process map based on observations to the best extent possible. After creating the process map, then we spend more time in the workplace to see how well the process map actually reflects reality. The current state, it also refers to current performance. So we want to graph current performance on a run chart or control chart. Now don't worry, we're going to get into control charts later. Not today. But what I want to emphasize is that we don't just take one measurement, and we don't just take a mean or even just one histogram. We want to get enough data to see how the process behaves over time. Now, this may be days or even weeks. So, to fully understand the current state or to get a clear picture of what is happening right now, we want to, one, observe the process. We never rely on hearsay or stories. We go and see what is happening for ourselves. Then we map out the current process, and this is what is most frequently occurring without judgment. Next, we evaluate the data using a run chart or control chart to see how the process is functioning over time. Then we discuss the current state information with the team and come to a consensus about what is happening right now. The important thing to remember is even though you have an idea of what the current state is, don't try to solve the problem yet. We still have a few steps to go before we get there. Thank you for watching. I'm Candice Garcia, and this is the Radiology Improvement Team Education at Stanford University.
Okay, let me switch over to my slide deck again. And so I hope that's helpful. The few things I would say is in terms of common problems, and I'm kind of troubleshooting this a little bit, but common problems I see when people are working on, working on mapping the current state is we are inherently, as residents and as physicians, we are inherently problem solvers. And so it's very easy to try to jump into trying to come up with solutions before we kind of get to mapping the current state. The other thing I see oftentimes is what you map down as the process doesn't actually reflect what's actually done. And that's most often happens if you have people who are mapping out the process that aren't actually doing those steps. Like if I, as a QI person, was trying to map out what the residents do, I may come up with a incorrect idea of what's actually happening. And so as you set about mapping the processes involved in your QI projects, I want you to, one is, don't jump to trying to identify where the problems are in the steps. Just try to map out, again, without judgment, like what actually happens. And don't map out what's supposed to happen. Like maybe what's supposed to happen is, someone's supposed to page this person and then they're supposed to do something and then whatever, but that's not actually what's happening on the ground. Like what you want to do is map as close to possible what is actually happening as opposed to what's like in the policy or what is the set out process that's supposed to happen. And so a few sort of technical details. You don't let these details kind of like get in the way of just starting to write down what the process is. And I'll kind of show on, I think I have a slide on like the Lean A3 method of doing this, which is just charting out steps. But if you're doing a flow chart, technically an oval is supposed to be the start and the end of the process. So you have an oval for the beginning, an oval for the end. This rectangles are activities or steps in the process. A diamond is a decision point. Usually it's a yes, no question. And then if the answer is yes, you go in one direction on the flow chart. If the answer is no, then you go in a different direction. And then you have flow lines going between the different shapes. And then within the shapes, you describe that step. And so what does that look like? This is an example I took from the IHI QI Essentials Toolkit, which you can access online. And I'll probably get the flowchart section of the toolkit, get some paper copies for us to work off of during the live session. But here, again, it doesn't have an oval for the beginning or the end, which it technically should, but starting with patient has acute symptoms. First decision-making point is triage and ER. Does the patient have evidence of MI, yes or no? If the answer is no, then you follow the flow line down to ambulatory care initial evaluation, and then you follow the line down to ambulatory care follow-up care. If the answer is yes, Then the next step would be early anti-ischemia infarction therapy. Next step would be inpatient evaluation and therapy. Then you have a diamond, invasive evaluation done, yes or no. If yes, then procedure indicated, yes or no. If yes, then you go to revascularization procedure. If the answer to either of those diamonds is no, then you go to ambulatory care, rehab, and follow-up. And so again, you can see this is very high level, and I really encourage you to stay out of the weeds, at least as you get started, and just start really high level, like, nurse has concern about a patient or whatever that first step is, decides to call on RRT, or like, you patient identified that has hyperglycemia, then what's the next step, right? Or, um, patient is planned to be discharged, decision made to make a clinic follow-up appointment, what's the next step, or whatever those steps are. And so I think what helps with trying to write it down is then it helps to kind of see all the steps, see the complexities, and then it'll help down the line when you start to try to identify where the different places are for change. But don't get to change yet, just write down what's happening right now. So what does that look like on the lean A3? That's actually down here in 2C. So 2A is identifying the gap. So that's the sort of aim statement. Here in 2C is the point of occurrence. So again, they're kind of hopping to change, but what you're trying to do is just identify what the steps are in the process. And so, this is another way to do it, is like step 1 is this, step 2 is this, step 3 is this, step 4 is this. And again, try to keep a high level, and then just write down what the process is. And so that's the main thing you guys are going to be working on at the live session. I do have another video I want to share. This is going over datas and measures. I didn't get a chance to show this video last time because of the technical issues I was running into. So let me end my slideshow and see if I can show this video real quick. Go back to Zoom, share. Okay. So I am going to play this video. Again, these videos are short. You can watch them on your own time. This is from the IHI YouTube channel, and this is on establishing measures. So I'll go ahead and play this.
Let's imagine a golfer who's constantly slicing the ball, sending it off at an angle instead of going straight. Now a coach advises her to switch her grip in a certain way. So she swings again and the ball goes straight. Next swing, straight. Next swing, slice again. Her coach says, that slice, that's because you reverted to the old grip. Next swing, straight. All sorts of measurement are going on here. She, the golfer, she notices where the ball goes. That's a measurement of outcome. And her coach, he notices her grip. That's a measurement of process. To improve, she needs knowledge of both. Unless she's committed to a randomized trial, which would be rather silly and wasteful, she can improve, but only if she notices both process and outcome, and if she and her coach retain awareness of the sequence, which swing happened when, and in what relationship to the grip. Now, if it's, say, intensive care unit infections that we're targeting, not a golf score, noticing gets a little more complicated, but the principle's the same. Keep track of the outcome sought, and keep track of the possibly relevant processes, the causes you suspect and that are working on, the changes that you make, and then remember the sequence. Graph it. Graph it using an annotated run chart. There's one other type of measurement that can help too. It's called a balancing measure, or maybe we should just say this, a side effect measure. These measures refer to things that might be inadvertently, undesirably affected by the change. For example, maybe our golfer needs to keep track of aches and pains as she alters her swing. Maybe a swing that's good for the golf ball is bad for her back. The ICU working on hand washing may want to watch out for hand rashes, or maybe for slowing down the care too much. Finding a good set of measures, outcomes, processes, balancing measures. That actually could be a project itself. You can improve your measures over time. And it's really not uncommon for an improvement team to spend some time developing ways that it's going to assess its progress, to find the measures that feel right, that feel practical, meaningful, inexpensive, user-friendly. And I remind you, seeking measures that have heart, that you care about.
Okay, so again, just giving credit to the IHI for that video. But you can see that I hope that golf example kind of gives you an idea of like outcome measures, process measures, and balancing measures. And I went over this last time too, but just to make sure everyone understands when you hear these terms. So the outcome measure is the measure of impact you want to make. And so in the very first session, I talked about reducing daily labs. So maybe the outcome you're trying to uh, make an impact on is CBCs per 1,000 patient days, and you want to get that number lower, or what's your average A1C? That's the impact you're trying to make. The process measure is a measure of the process or changes you are going to make, and I don't think you'll actually get to defining your process measures until you define what your changes are. So we're not quite there yet, but just knowing what's meant by a process measure can be helpful. And so in the golf example, it's changing your grip. The outcome measure is hitting that ball straight or how far you're hitting it or whatever. And the example of like CBCs per 1,000 patient days, maybe the process measure is, was individualized report cards on lab ordering habits given to the residents. When did that happen? What were the resident attitudes as measured by a survey? Or what's the usage of the order set that has like a Q day order, right? Or for A1C, maybe it's how often changes are made to medications. How often are A1Cs being ordered might be another process measure. And then the balancing measure might be a measure of the unintended impact or change your change might make. And so in the lab reduction example, it might be, we're ordering less labs. Is there an increase in rapid responses or code blues because patients are decompensating that weren't identified earlier because we weren't getting daily labs, right? Or maybe it's a good thing, right? That we see as a consequence of our change, but might actually benefit patient care, like reducing PRBC transfusions or reducing phlebotomy-induced anemia. And so once you get your measures, the idea is to chart it out over time, as you saw in the first video. Just a single data point, it doesn't really tell you much. It could be spurious, it could be random. What you really want to see is over time, what is happening with your measure. And so, these are time points, 1, 2, 3, 4, 5. These will usually in RQI projects be weeks or months. Sometimes it's days, but usually it's weeks or months. And then so week over week over week or month over month after month, what is our number of RRTs or repeat RRTs? And then you just chart it over time. And then this center line is usually a median. We'll talk about down the line, when we get to control charts, like when do you use a mean as a center line. But I think the main thing is just to start charting your data. And I think the nice thing about charting your data this way is that there's intuitively, you can tell if your process is actually improving or getting better or getting worse, right? And so here you can tell, even though there's data points on both sides of this line, that in general, the measure is about the same going across the graph. Now, there are ways of actually interpreting run charts for significance. There's these terms of shift, like having 6 points above or below the center line, trends, where there's a bunch of data points in a row, usually 5 points going up or going down, an astronomical point, so a single data point that's obviously way out of the norm. And these are ways of telling if there is some sort of significant thing going on with your measure, right? It doesn't say why, but at least you can tell here for these time points, there was a shift. And maybe it's because, you know, someone else was working that day, or the data was getting collected incorrectly, or there was a change in your process, or here, you know, maybe that's like a holiday or something. And so maybe it's something that you have control over or something you don't. And so but these are some things, and as you graph your data and as you look at it, I can help you with interpreting them. And so you know, that's it for this session. The main objectives or the main goals, things to work on now, are going to be with your projects, really clarifying the problem, getting a data plan. Like where are you getting your data? Where's your outcome measure? How are you getting access to that data on a regular basis, and start charting it and start looking at it. You don't need to start interpreting it, start planning change yet, but just establish, you know, what is your outcome measure? What does it look like, and start to chart it out and kind of take a look at it. And I think that'll help you with motivation as well. Start to think about your aim, right? So what is your aim statement? What are you trying to, what's your goal? And then what is the current state? So start to put those steps down. You don't have to get it exactly right, but I think getting something down on paper by the end of the live session will be important. And then next time we'll talk about analyzing the problem, and then we'll get into how do you figure out where, you know, the problem areas are, how do you decide on change, you know, that kind of thing. And so, you know, even though this is the QI curriculum, we're not improving any quality yet, we're just mapping up current state. And so I will stop the video and look forward to seeing you at the live session.